Atrial fibrillation, you want to control that rate. You want to control that rhythm and decrease the risk of embolic stroke. That is your objective for management. Is that clear? And you do these, then for the most part, you should be able to manage your patient effectively. How do you control the rate? Slow down the cardiac rate by maybe digoxin. Hold on. Now, what you know conventionally for digoxin is a positive inotropic agent. Think about what I just said here. A positive inotropic agent in this type of setting would make no sense. Because if it was an atrial fibrillation with increased heart rate, what does it mean to give a positive inotropic agent? Is that why you're giving DIG? Obviously not. All right, so even if you knew nothing about digoxin and its secondary effect and why it's so important to give it here, then you, by common sense, you know there has to be another mechanism that comes in handy. It's the fact that it slows down AV. It slows down the AV conduction. Is that important? Yeah. That atrial rate, that P wave, is ridiculously high. So if you're able to slow down the conduction a little bit with DIG, then it works. Is that clear? Now, digoxin, of course, in the setting of, let's say, a congestive heart failure patient, and then you start thinking about inhibition of sodium-potassium pump, increasing intracellular sodium, increasing intracellular calcium, thus bringing about positive inotropy, right? That makes sense for congestive heart failure. It would make sense here. This, using it because it's slowing down the rate. Beta blockers, obviously. Now, that one's easy. You slow down your beta 1, and by doing so, you should be able to control that rate. Rhythm control. How do you do this? You reestablish a sinus rhythm. What does sinus mean to you? Sinoatrial. And that sinus rhythm was completely irregular. Antiarrhythmic medication. Such as, well, it depends. Right? It really depends. Now, at this point, what I'd like for you to do from pathology, because at some point when you bring in the management issues or the management administration, you want to understand the concept first and then maybe choose a drug that makes most sense for that particular arrhythmia. Okay? So at this point, while you're thinking about the SA node, you're thinking about things like the action potential 403 with the SA node. What are they? 403. So what is the depolarization phase here for an SA node? Phase 0. Is that sodium channel? Not for an SA node. It is the calcium channel. Is that clear? So where is the sodium here in 403? Phase 4. Because it's funny. What does that mean? Remember, it's called a funny channel. In other words, it's a sodium channel. So we'll talk about this as we move forward. Well, let me ask you this, because at some point, when you do take a look at pharmacology, and I want to make sure that we reinforce it, is the fact that how is it that you're able to control that sodium channel with phase 4? Is it a class 1 drug? Good, it's not. That phase 4, granted, it's sodium channel. It is not voltage gated. Really? Dr. Raj, I don't think you know what you're talking about. Oh, yes, I do. That phase 0 in an let me talk to you about another action potential. If it's phase 0, 1, 2, 3, 4, that's mechanical activity, isn't it? Right? Mechanical activity, 0, 1, 2, 3, 4. Tell me about that phase 0. That's the voltage-gated sodium channel. That's the mechanical activity, let's say, of the ventricles. So that phase 0 in 0, 1, 2, 3, 4. Are you picturing that action potential? Close your eyes. There it is. That phase 0 is a voltage-gated sodium channel. That's class 1. Let it be 1A or 1B, what have you. Okay? But here, in SA node, and its action potential of 403, and the sodium is at phase 4, funny, then it's controlled by ligand-gated. Really? Mm-hmm. Because that phase 4, you control it by giving a beta blocker, a class 2 type of antiarrhythmic. All I'm doing here is laying down the foundation, or should I say reinforcing the foundation, so then we understand the pathology and how you manage this. If at this point you feel confused, you feel a little frustrated, or you've lost what I just said, repeat what I'm telling you and take a look at your normal physiology of 2 action potentials in the heart, and then take a look at antiarrhythmic drugs, and you put all this together. All right? All right. Then you do electrical cardioversion. At some point, you have to cardiovert. You have to. because you talk about atrial fibrillation, because you want to get that rhythm under control. Decreased risk of embolic stroke. Now, this one we've mentioned a few times. You want to use anticoagulation. You're worried about CVA, which stands for cerebrovascular accident, a.k.a. stroke. And you can prevent this from happening by giving a warfarin. All right, so in other words, you're thinking about the mnemonic. Well, I do. Use whatever you want. WEPT. W, warfarin. E, extrinsic. What test are you going to use to measure warfarin? PT/INR, of course. Now, decrease the risk of embolic stroke with CVA. CHF, well, aspirin alone, hypertension, age of greater than 75, diabetes mellitus, and stroke. So ultimately, it's a score that you're going to give. Now, depending on the score that you're going to give, meaning to say each one of these conditions that you're seeing here is given a certain point. And so therefore, whatever point that you're going to get now in this column then is going to prevent a stroke from occurring. 0 to 1, aspirin. Greater than 2, there's Coumadin. What is Coumadin? That is your warfarin. High risk of CVA, enlarged left atrium, left ventricular dysfunction. So these are the individuals that we talked about already, in which let's say that you have atrial fibrillation that took place from mitral stenosis. Think about that for 1 second. Hi, Doc. How are you doing? What just happened? Well, that was a patient of mitral stenosis. Why was it talking like that? Because, well, the left atrium got enlarged due to mitral stenosis. It was an opening snap, a diastolic rumble. The left atrium is huge. I'm having a hard time eating. Sound like Marlon Brando, perhaps. But left atrium becomes enlarged. It's compressing upon the esophagus, dysphagia, and also left recurrent laryngeal nerve. Hoarseness. So, what are you worried about with that enlarged left atrium? Development of a thrombus, huh? Sure you are. Left ventricular dysfunction, myocardial infarction, and if it's not working properly, once again, high risk for stroke, cerebrovascular accident. That is the objective of this entire slide, and those are the points that you want to give. It's called the CHADS point.